So one of the things that we often say in the work that we do together is repetition is key. So there will be potentially a bit of repetition as to what has been said already this morning. And we make no apologies for that, because this is a message that we have to keep hearing and hearing and hearing, and that drip feed, and eventually it gets in there and we can work and move on.
So Hannah, what you said, none of it was nonsense, because we're going to say the same thing.
Yeah. So I'm Mary, and this is Nicola, and Leona had introduced us earlier. So I'm still in my core role. Nicola has changed role from the work that we were doing during COVID, and that's what we're going to focus on today. So I work in the Acute Directorate in the Western Trust. So it's all the physical health stuff. So it's the ED staff, it's the cancers, the diabetes, all of those problem areas. And Nicola, do you want to?
Oh, I work now. I used to work in the Western Trust in paediatric psychology, and then during COVID, Mary and I took time out of our substantive posts in order to deliver some of the staff, develop the staff care package that was delivered during COVID. So, but now I work for the Department of Health in Northern Ireland in the Regional Trauma Network.
Okay. So I suppose in thinking and preparing for today, and it is thinking, well, what's happening in the NHS and how does that translate across? But there's so much of what Hannah said and what you're dealing with that we kind of experience similar things in the work that we do as well. And it's thinking about all the first responders. It's the ambulance crews, it's the fire service, it's yourselves who are there at that cold front. And you will see things that we never see. And we get the sanitised version often, even for the ED staff that we think are at the cold front. They're getting the sanitised version compared to what you're getting out when you're on the roadway at the road traffic accident taking the photographs. And it's even in terms of like recent online media where there's complaints about, oh, well, there's photographs of this and from families and things like that, and this shouldn't be published. But that's also the sanitised version, you know, of what you're seeing, and that's I think what people forget as well. And you really do have such a role and responsibility to the wider public in terms of what you're doing, but it's also really important to get the stories out there and get the messages told. So we're going to talk a bit about self-care and compassion and psychological safety and the NHS and particularly in our trust. But I suppose a lot of the messages that we're given aren't particular to the Western Trust, and we're very conscious we're talking to media folks. It's not just the Western Trust that does this. This is common in all services, and we will link regularly with our colleagues who work in the other trusts across the north as well. Okay. So setting the scene, these little messages will be referred to as we go along. And I suppose if we think of the frayed rope, and when I was driving up this morning, I was thinking, well, actually, we're all that bit of that rope where we're connecting, and the conversations that you mentioned, we're connecting to each other, but it's also, think, rope binds things together, it connects things, it can fix things, it can repair things. But it's also, if we're pulled in too many different directions, or that tension is there for too long, we start to get a wee bit frayed. And Hannah used the message exhaustion this morning. Frayed is another good way of putting that, exhaustion. So when does it get too much? When have we pulled ourselves in too many directions? When have there been too many competing demands? And how do we recognise that we're just hanging on by that wee last thread whenever it's about to break? The superheroes I'll come back to, and Nicola will talk a little bit more about the baby mobile and the context. So I suppose in terms of the context, it's also thinking about the culture. And whilst, you know, we're here today thinking about the culture in the newsrooms, there's a lot of work needs to be done in terms of the culture in the NHS as well. We're very much, you know, we're paid to look after everybody else and fix things and make everybody else better. But who makes us better? I have a lovely slide that I sometimes use, and your little message about watering the plant. And mine says, we're all houseplants with complicated emotions. I kill all my houseplants, so I'm really concerned about how we look after ourselves, if that's the model that I'm going by. So thinking about setting the scene, the healthcare heroes, we're all aware of the COVID experience. And the Thursday nights, let's clap for our NHS heroes, and then it's a bit like waiting lists, and I want this done, and how long does it be, and it goes back to normality after a little while. But during COVID, more particularly than ever, we did see our healthcare staff as being superhuman. Going those roads, we do think we're superhuman all the time. But it is a bit about what we face and what we're expected to do. And in healthcare, it is that kind of most basic thing. we're saving lives. And it does make so many of the people that we work with heroes, but not everybody in the health service views themselves as being a hero. And certainly, I don't think that we would view ourselves like that. We're much too humble for that. But it is thinking about what they do and what they're expected to do and how they're doing this day in, daily. It is about dealing with life and death. It is about breaking bad news every day. It is about trying to absorb and manage and contain the emotion, the shock, the disbelief, the despair that so many of our patients present with, and also their families as well, because it's not just the patient, it's not the breast cancer in bed 4, it's the person, it's also their family. And particularly what a lot of our staff will find challenging is when you're dealing with people who are dying and dealing with the family system around that. And that I suppose we would talk about a position of privilege that we are in and being allowed into those really, really particular moments. And I suppose being there to manage people in those really, really, really vulnerable times. And Hannah talked about normalising conversations and how important it is for us to recognise the work that we do in the NHS and have those conversations. One of the things, I suppose we weren't necessarily going to talk so much about it today, but one of the things that we do in the Western Trust is debriefing, and we have the CISM team in the Western Trust, the Critical Illness and Stress Management team, and that was set up in around 2015, 2016, and that was because often people were coming to the psychologists in their teams when something happened and say, well, come and support us, and we were coming and doing that, but thinking, is there a better way of doing this? So we developed a team to outreach into all of the teams across the directorate, but it was also the recognition that difficult things happen in line of your work, but it's not always normal, that even though this is what you're paid to do and this is what we know does happen all the time, there are those ones that just stay with us or impact on us, or the ones that you go home and you can't switch off and it continues and continues. And Hannah mentioned about things being re-triggered at a much later stage. And when we go in and we talk to a room full of people, we'll have those, as we said, I was listening to Radio Ulster yesterday and they were interviewing Declan Lawn, who wrote Blue Lights, and they had a police service person on afterwards, and they talked about the police service going out to a scene of an accident or a scene of a crime, and Nicola and I get in, and I'm the rookie cop, and I'm like, oh, God, I know, just everything's so new to me and so shocking. And Nicola said, I've been here 20 years, I've done this job, no big deal to me. And the person on the radio used the words, they're desensitised. And I thought, yes, that's fantastic, they're recognising that. And we see all that all the time in health service as well. And we'll set up debriefs after something untoward or more traumatic has happened, and you'll get staff coming, and sometimes it's the consultant, I'm only here for the rest of them. I don't need this. I've been doing this 20 years, but the wee young ones, I'm there to support them, without recognising, actually, this has impacted on me too. And when you do talk to them and the conversation starts and the importance of conversations, it's like, oh yeah, and there was another one, and that was like 10 years ago, and then I remember, and you're like, okay, we're really going to focus on this one today, and we don't always recognise what has impacted on us and what's hit us and what we're carrying with us as well. And we talk about being a sponge, you soak everything up, all that, but when you squeeze it out, there's still residue left, and that's the bit we forget, and we carry that residue with us. Hannah talked about moral injury, and I'm going to talk a little bit more about it, but it's sometimes we see the healthcare heroes, but we don't see what's happening afterwards. And often it is, and we'll talk to your staff, and it's like, I'm in room D, and I'm dealing with the person who's maybe dying, and I'm getting everything sorted there, managing that, and it might be a patient who's been in and out of hospital for months and months, know them really well, know the family really well, the impact of that, go out of that room, and it's like, I buzzed for a bedpan 3 hours ago, and nobody, and it's like, okay, wash that out, go and do the next thing, and then you're on to the next cubicle, and when do you get to debrief? And you're going home at the end of your shift, maybe the people that you've been on shift with have left already because I'm still doing my notes late, and who do you get to debrief with? And the thing that we recognise is that often we're not maybe even on the same shift as that person for the next few days because they're on leave or I'm on leave, or you mentioned just even working freelance. those people who maybe work from home, who are going and doing something, who do they touch base with? And we have a lot of workers who still go into the office in the morning, they're out doing calls, not back in again. And thinking about, where do you debrief? Is it sitting in your own, in a corridor, just grabbing 5 minutes? And sometimes what we'll be saying to staff to do is like, can you just go to the toilet for 5 minutes? Just say you have to go to the toilet, go and shower your head out again. And sometimes that's the only break that you're getting. The little picture here, and that to me is moral injury. And that was one of the pictures we came across during COVID. And it's when staff weren't allowed to have physical contact or really limited physical contact with the patients. And the moral injury for the staff was that they felt they weren't able to provide the care that they would normally provide in terms of that compassion, that understanding, that self-care. And this was something that was devised where the balloon, the gloves were filled with warm water and put in the person's hand. So for that person, they felt like somebody was holding their hand. The really simple stuff. And sometimes we forget about the simple stuff. And for the staff, it might have seemed ludicrous, but they felt better about feeling that they were connecting with that person and that the patient that they were caring for was receiving the best that they could provide to connect in again. But how challenging that was for staff going home thinking, I didn't do a good enough job today. And that's the thing about all that we do. If we can go home and think, yeah, that was a good day today, even if it was traumatic, it's like, I got the story, I got the pictures, I did well today. But if we're going home and thinking, I should have done better, I could have done better.
Has found the strength during COVID to get up the next day and get back into work just amazes me.
Yeah, and that's one of the things I talked about doing an interview, and I'd mentioned that it was like the Troubles, and then that was the headline, and I was like, oh no. But it was like that because it was day on day on day. And what we recognised, I don't want to steal your thunder either, but, what we recognised very early on was the first wave of staff were like, yeah, we've got this, we can do this, we're going and galvanised, like going to battle themselves, the superhero costumes on, and feeling we did a really good job here, we did well. And then we thought, because it was St. Patrick's weekend, it was that early March weekend, we had conversations with one of the directors in the trust about this is coming, it's coming in the next week or two, set up services for staff, and that's what we went and did. And staff got through that, and people were willing to put their name down for whatever was asked of them. And then thinking, right, well, it's going to be over by the summertime. I know, September, it'll be sorted by September. And then it was like second wave, third wave, and you could just see that resolve from staff going, I can't keep going to the well and giving and giving and giving when there's nothing left to give. And when we look at, you having to scribble out now and say, no, I'm not saying that.
Yeah, take out that bit. Hannah said that bit. Mary said that bit.
But it's that thing that we also recognise, and there's so, like media this week, there's a lot about pay rises for NHS staff, but also about staffing shortages. And that's because so many people left then during COVID. It's like, yeah, I was going to retire in a couple of years' time, but like, I don't know if I can keep doing this. And people changed what they did and how they did it. There's so much expertise lost as a result of all of that as well. And that's the same for you. So whenever you go off and do, who's going to do your job and how they're going to do it. And that's something that we contend with all the time. But that's also why you need to get in early and recognise the impact that some of the work that you're doing has on you and try and mitigate against it. And we don't always realise it until it's too late. And it's a bit like you have your 2 weeks in Mallorca and day 2, 3 and 4 you spent in bed because you're just flatlined by the coughs and the colds and it's just you've pushed and pushed and pushed your body, and it's only when you stop that it's like and we often do get sick in those few days before we go off on holidays, and we just know, oh no, I'm on holidays.
Because your immune system's compromised.
Absolutely, absolutely, and Hannah mentioned that as well. And in healthcare, back problems. So many people present for back problems. Is it that I'm lifting my patient the wrong way, or is it just stress?
I got sick in Dubai last week.
Mm-hmm. Yeah, it'd be much cheaper to be stuck at home.
I know.
So Hannah mentioned vicarious trauma, and you know we've touched on that as we've gone along, and that again is thinking about the moral injury. It's thinking about the need to invest in the health service that we're mitigating against all of this. Vicarious trauma, Hannah had given her age, I'll give mine away as well. My first post was in Oma, the year after the Oma bomb, and the people coming through at that stage. But it was also, we were getting referrals for people who were living 40, 50 miles away, who hadn't been in Oma that day, who didn't have any family members in Oma that day, but they'd seen it in the news. They'd seen the photographs, they'd read all the media reports, and that triggered something in them. And they presented with PTSD when they weren't there. So it's thinking about what we do and how we absorb that, but also what can be re-triggered. And what we talk about sight, sound, smells, things like that, the most innocuous things. And you're brought back to something that happened 5, 10, 20 years ago. And mostly it is because those things weren't resolved at the time. We carry them with us. Okay. I was part of a workshop in cancer services, and that's one of the areas that I work in, the other week, and we talked about how to improve services, how do we do things differently, again, in light of limited resources, how do we get the best for our patients. But one of the things that I was talking about was how do we look after ourselves, because to me, a lot of what our other healthcare staff were dealing with during COVID, our cancer service staff deal with that day and daily in terms of the death, the dying, the breaking bad news, the impact on the wider system. And at our table, one of the consultants said, yeah, it'd be really good to do all that, but I have a really busy clinic and I don't really have time to take out, and I do. And it's like, well, and I said, well, how do you talk about the difficult things or the news? Well, sometimes I'll go out of my room and I might meet a colleague and we'll go for a coffee. I said, well, what do you do if you don't meet that colleague and they're not there that day and you just go home? And I suppose the thing to remember is, what are we bringing home with us? We're giving everything in work and doing all that. What kind of a spent force are we when we get home? If you give everything to everywhere else, who do we not show up for? We show up in work, but who do we not show up for? And they're the people that actually rely on us most. It is our families, it is our children, it is our loved ones, and how important it is for them. And when often we're asked, what's more important, your family or your children, your work? You'll always say, oh, my family. But what do we give to them? What do we keep for them? And it's important to remember that too. So one of the slides I did put up in the thing was all of these, and they're kind of thinking, yeah, all these studies are happening, but yeah, they're in other hospitals. They're not in my hospital. They're other teams. Those people aren't really managing themselves so well. And they kind of think, but that doesn't apply to me. And often they'll not remember this until they are part of the statistics. And I suppose days like this, so important to have, because you might be sitting here thinking, I don't need that. That's not for me. Someday or at some stage, you will remember, something will trigger off, and thinking, who do I go to? What do I do? Leona will know, and they'll go to her. And that's why it's important to have these conversations, because you might not need this now, you mightn't have needed it in the past, but in some stage in the future, you may need it, or someone else may need it as well. And we talk about in the SISMs and the debriefs, we talk about the unique incidents that we're part of. You become a unique group, and even other people in your team who weren't there involved in that incident, they don't really get it. They don't really get what exactly it was like being involved in that particular incident. We have an understanding, but people who weren't there don't really share that understanding. So that's why it's so important to connect back into people who really do get what it was like. And it's also then we go home and their families are like, oh, you're a bit narky today. Who rattled your cage? And they don't get the type of day that we've had. And we can't, with patient confidentiality, we can't go home and say what's happened to someone or what we've seen or what we've witnessed. If your name's attached to an article or a photograph, people will say, oh, you must have been there. What was that like? And it's like, So we can't necessarily go home and discuss things, but they know when something's wrong. They know when to kind of, just stay out of their way for an hour, or let them go for the run, or do you want me to run the bath for you? And it's really important that families do know that and do understand, and we have that support system outside of work as well as in work, because both of them impact on each other. Hannah mentioned some of the things in terms of PTSD, what we can experience if there is a degree of trauma or overwhelm in terms of specific things that we have been witnessed to or been involved in. And I suppose the last thing on that is the one that's really critical in healthcare, because if we are compromised in terms of being traumatised and the brain kind of shuts down and we can't really make sense of things, or we make poor decisions in healthcare, there are very serious consequences if you're not making the right decisions. So all the studies looking at psychological safety also look at the physical safety as well. I've had another wee slide in there. Okay. Talked a bit about the cumulative effect of what we do in the day and daily, and where do we start with? And this might be, if we think, don't even think about work situations, but this might be, I went out this morning and had a flat wheel, and then maybe I got sorted and I got on the road, and then I realised, like Nicola, she'd forgotten her tickets for Bruce Springsteen, and I had to turn it and go back.
My lines, Mary.
There's another, and repetition is good. So there's something else that's happened. And then there's a phone call from school whenever you're in the middle of your working day. The child's sick and think, right, okay, my husband's in Belfast and I'm whatever, and Granny's like, okay, just can I keep them for an hour and we'll get there? All of these things, we build up. And they're the little things that can cause us to not get. And it's thinking about the frayed rope. What's the little bit that causes the break? And sometimes it is the most innocuous thing will be the thing that tips us over. And again, thinking about work and figuring out what's filling your cup and what can we empty out, what can we get rid of to have that capacity to do with it. And when we're talking to your patients and we talk about stress and saying about all the little things that build you up, that you're at your capacity and ready to tip over, and what you need to do. And Hannah mentioned lots of really good suggestions about trying to reduce that. You mightn't get to baseline, but how do you reduce it that there's just a wee bit more flexibility? And that's something we have to constantly do. There's no one quick fix for that. So COVID, that we're going to focus a little bit more on in terms of the staff support, is something that, I suppose took everybody by surprise. Even though we heard it was coming, the reality was so different. It changed everything that we did in so many ways, the climate in which we lived in, how we do our work, how we do it day and daily. And the thing about COVID is normally, if there's something going on in work, you can go home and get away from it. If there's something that's going on at home, I'll go into work. And I used to say when my kids were little, I'd come to work for my sanity. But with COVID, I couldn't get away from it. And then it's also thinking about the pressures of families. It's like, do you really have to go to work? So if I go to work and I pick up COVID and I go home to my elderly parents and they get sick and something happens to them, so many of our staff had to move out and live in separately. But it's also then, if I as a staff member go onto a ward and bring COVID into a ward where patients are already vulnerable and something happens to them, so we couldn't get away from it. The only good thing was that, and my niece was working in Manchester at the time and saying that when they come out of work, people were trying to steal their passes, their hospital passes, so that they could get to the front of the queue in Tesco.
I thought you were going to say the only good thing about COVID was we worked together for 2 years.
Yeah, that was the very best thing, And that's the bit I miss dearly, because my connection and my safe space has gone. My body system, when we talk about body systems, that's gone. So I've been grieving for the last few months. Role of managers, Nick is going to talk a little bit more about as well, and again you highlighted it, Hannah too, they were the people kind of stuck in the middle, messages from above, this is what you need to do, you need to make sure all your staff are at work, but also then from below, initially it was about PPE, and have we got enough PPE, and where do we get it, and how do we need more? They've got more than us, and even hearing about people kind of compromising and using bin bags and things like that, and care homes and things that just weren't good, but then also for us it was about the psychological PPE and how do you day and daily put on your superhero costume to keep going in and doing what you're doing. You're going to talk about the model and self-compassion, and I'll not talk about that. Okay. So psychological safety, which we mentioned as well, is that ability to share thoughts, feelings without risk of damaging one's reputation or standing, and that's the bit that Leona talked about, Hannah talked about, and that's where you go into work and say, well, actually, I'm having a tough day today, or this is really getting to me. Or one of the comments when we do our debrief sessions, And initially in the hospitals, and a lot of the hospitals do debriefs, but did you have the right equipment in the right place at the right time? Did that person respond to their brief? It's all about the practical, the technical. But people weren't asking the questions. Well, are you okay after that? It's about are you okay really? So those questions weren't being asked. And when we started doing them, it's word of mouth now, and it just snowballs, and people are looking for them more and more. But it's about having that space where people are able to say, actually, no, I don't think that was done well, or we could have done things better, without anybody like going in the defensive and saying, well, what are you saying is wrong? And being able to be open and honest. And in the Western Trust, our chief executive would have talked over the last few years, Anne Kilgallen, who has left, would have talked about transparency and the need for transparency and admitting when we get things wrong, but also that's how we learn, that's how we get things right. But it's also thinking about, it's not a one-fits-all approach. We have loads of different personalities. So one person might be quite happy to get up in the room and like even you sharing your experience, and that is really brave, and somebody else will be like, oh my God, don't ask me to speak. And you have to have an approach that's going to fit everybody as well. And that's about creating spaces, and I know this afternoon it'll be more about creating those safe spaces for people to feel that they can say what's going on without any fear of retribution or anything being held against them, or I'm compromising my job. Or I remember someone saying years ago who was sent to speak to me that I got really upset because of somebody I was dealing with, because they reminded me of my son. And this was somebody who they weren't able to save, same age as their son, looked identical, weren't able to save them. They got upset and said, are you sure you should be working in this department? Do you need to go? And it's a bit like, that's normal. We're humans. We're not robots. We are human. And if we lose our humanity and we lose our compassion, working in the health service is not for you. And that's the same as well. You know, after a while, you can become desensitized to some of what you say or some of what you do. And you need to do. You need to put on your armour to go out and hold it. But we can't lose our compassion. And that's the key. And sometimes when we're burnt out, I say, oh, I have nothing to give anybody else. And that's what we need to remember too.
Thank you, Mary. Do you think Mary's an introvert? You know, that last slide there. We'll do a personality questionnaire later. Anyway, thank you, Mary. Pleasure, as always. Usually we do this in Zoom and we just are interrupting each other all the time. So standing at a mic, we had to be a bit more careful, so it was hard. Anyway, our task, it was kind of a self-appointed task really, was to develop a programme then in order to promote psychological safety and providing a psychologically safe environment really, and help provide something to meet the needs of the staff. So we turned to the evidence base and to the work of Tate Shanafelt in the initial stages. And I have to say, Mary was the one who found all the research at the start. But Tate Shanafelt, interestingly, his job at the minute is Chief Wellness Officer at Stanford. I thought, what a great job. I think I'd like that job. You just go around making people happy or helping people be happy. I thought, that's super. Every organisation should definitely have one. But Shanafelt and his colleagues have done a lot of research on the things that Hannah was mentioning earlier about burnout, about moral distress and moral injury, and looking at what staff needs were in the face of all of those things that were going on. So whenever we were looking at the evidence base together with what the staff had already told us, what we realised is rather than anything that was about a general stress reduction technique or resilience, which I also hate as a word, a resilience training, we needed to elicit the context in order to promote understanding. And as Mary has already said, there was no one size fits all, so we needed to have a suite of options which were available for all of the staff. And as part of our work, we wanted to make sure that we understood the different concerns, the different sources of anxiety or fear. Some of us work really, really well under pressure. I do. I work really well because I did this talk last night at 12 o'clock. I'm really good at the last minute. I don't do that prepare weeks in advance. It's just like, right. I think it's because both Mary and I come from acute environments, me with peds and her with adults. So we do best under pressure. Other people do best in other circumstances. And then we developed the model from that. But the model itself and everything, all the work we did was really underpinned by some of the C's that have been mentioned already in terms of communication and connection. And if you remember, Mary put up the model of the mobile earlier, the baby mobile. And we're going to come back to that because the message of connection and stability is really important in that. I stole this slide yesterday, told you it was last minute, stole it from a talk I was at from the Safeguarding Board in Northern Ireland. And it was really because the other thing we had to consider in developing the model was about the culture, and recognising that culture change takes time, and being aware that we need to take on board as well the trauma that was happening, as well as the traumas that had existed in the past. And this was a slide put up by Orla Connolly, who works for the Safeguarding Board. And one of the things that I thought was most important in this model was the fact that you start, and this is when thinking about whatever we're trying to develop here as well, you start with a vision here, and then you do the scoping, and then you're looking at change readiness, and somewhere out here you actually get the change. So these things take time. We didn't have a lot of time whenever we were obviously working in response to COVID, but we tried to make sure that we were using some of these elements as well, and being aware that things do take time. And you'll see from a later slide how we built on little seeds of change, that it wasn't a dramatic thing at once. And we adapted some of the information that Mary had found from the Shanafelt paper to develop our model. And our model was based on that, but really had these sorts of 5 central areas whenever we were looking at it. It was about the different things that staff need in order to be able to increase safety in uncertain times. And to see there that it wasn't just one area, it was 5 whole different areas that were being looked at. And the importance of things like Protect Me, in order to make sure that there was the right PPE, testing, etc. Prepare me, give me information, give me training, and give me support. Support in terms of the physical things that are needed, and looking at rotations, and especially the psychological needs, which are often forgotten. And then care for me. One of the most basic and important things, and I'm repeating it, and I'm going to repeat it again later, is the importance of expressing gratitude. And Hannah mentioned it, and it's on one of our slides later, because it's so often left out, but it can mean so much. And lastly, the hear me. How do people's needs be listened to by the organisation? But what we needed to do was pull together those models and our own model and all the information that we felt was really important to share. And we made this into a paper which was called Increasing Safety in Uncertain Times. And we did that because we wanted there to be a product. We wanted there to be something which could be disseminated right across the organisation. It was primarily given to managers, but it was available then across all the different levels. And that was so that everybody got the same information. In relatively the same amount of time. And it's something which we used over and over and over again to support the things that we are saying verbally. And you'll hear about some of the more verbal delivery that we did in a wee minute. And it was also so that it could be accessible and could be easily accessible by a number of different people. I'm going to take you through some of the things that were in the paper. We've already mentioned the different models, but this is one of the things that we used then to try and help people remember our messages. And it was a mnemonic called Vital Grace. And the reason we pulled it together was to promote behaviours to help others feel valued and feel safe, especially in the times of uncertainty. And whenever we do this as part of the webinars that we delivered, as well as being in the paper. And whenever we're doing it, we'd often get people to guess what each one means. But in order to save time, we'll not sit and have a quiz. But the V stands for visibility, or being seen. And that was really important to staff, because they felt it was really important that the managers and the senior people in the organisation were visible, that they were seen, that the staff knew that that everyone was in it together, and it wasn't just the staff on the ground doing all the work. T is for transparency. Mary already mentioned the chief executive at the time had a big ethos of transparency and the importance of ensuring people knew the truth, and that encompasses honesty. And that was something that people came back to time and time again. They didn't mind if people didn't know the answers, but they wanted to know the people didn't know the answers, and saying I don't know had so much more power than not admitting the people didn't know. A is for actioning, that whenever you say you're going to do something, that you do it, that it's not empty words. And L for listening. We're going to come back to listening again, but it's very much that actively, and to be able to hear and then to enable the actioning. And we've got another few quotes about listening. It was one of the most important actions, I think, that we experienced. I should have got you to guess, G, since we mentioned it several times, but it is gratitude. And there was some small things that we did, Mary, in other presentations, as pictures of some of our medical junior staff receiving chocolate at Easter, And you would have thought, wouldn't you, that it was like about £100. But it's almost like, oh my God, we've received something. And Mary had worked really hard to make sure they got these Easter eggs at Easter, but they were really delighted by it. Repetition, repeating the information again and again, because we know whenever your brain, and we'll come to an illustration of that in a minute, whenever your brain's in any sort of state of trauma, you can't accept or receive the information, you don't hear it. So often people say, we told them that. And we'd see this all the time in some of the work we did with the families on the paediatric wards. You know, the doctor will say, well, I told them that already. Why are they asking you? And you go, yeah, you told them, but they didn't hear it because they weren't in a position to receive the information. And that's so common time and time again. Acceptance links in really strongly to psychological safety, because knowing that what you're saying is going to be received and that it's safe to be able to say it. That everyone's treated the same, and Mary's already mentioned that, and the importance of that standards, because otherwise people feel thwarted, and empathy, that importance of communicating the message that you get it and you're not alone. So this was all some of the key messages that we used whenever we were delivering the information, both in the written form but also in the webinars. And we had listened to what the impact was, and we looked at what we could do. We took on board a lot of what people had said. We were really mindful of that information that Hannah had given in terms of the Deloitte quote, that when you're proactive, it saves a lot of money compared to being reactive. And we know that that rate of investment is massive in terms of staff wellbeing. And the offerings that we developed then were really a suite of options in order to try and make sure we reached as many people as possible, and we reached people in the manner that was best for them. There's something that's not up there, which was a helpline, which a lot of the trusts put in place at the time of COVID, where people could ring in for information or for support via a helpline. We also had set up something called psychological support email, which lasted probably for over 2 years, didn't it? Where people could use that in order to contact, to make contact, to request input, and then more laterally to make suggestions about things as well. We developed team staff support sessions, which were delivered initially. I know we both did a lot of them on the COVID wards, not actually on the wards, but in the safe areas out just beside the wards, in order to support the staff there, and meant that they didn't have to come too far. But that was whenever we had organised times, and staff would come along, really for that supportive listening sessions. And then we really got the message that we needed to make sure that it was the managers that were hearing the key things and that it was being disseminated from them. So we organised a set of webinars for managers, and now it's part of the ongoing training programme in the Western Trust. So a lot of the products which were developed in response to COVID are now staying and being used in order to consistently promote staff health and and to ensure that mental health spaces is good. The information that went into the webinars we're going to look at in a few slides in a minute. React Mental Health, don't know if you're aware of that, Hannah, or from our other colleagues from England or Scotland, but that was set up, really, what do you call the institution that set that up? Yeah, it was it was set up a lot for veterans, but really it was about helping people have safe conversations about emotional things. So it was really about staff would often say to their managers, well, I don't want to say anything because it might make them worse. I can see that they're struggling, but I don't want to address it because might break down. They might think it's inappropriate, etc. So Mary and I did training in React Mental Health, and we also did the training for trainers in order to deliver the training to others. And the React Mental Health's now been rolled out in the Western Trust as well through some of our colleagues. And it was really simple because it's those 5 elements where you recognise that something's going on for someone. And then you engage to be able to talk about it in a safe way, and it really enables people to do that without feeling that either they're going to be threatened or by the information, or that the other person's going to feel threatened. It encourages the active listening. There's a risk check as part of it, but it doesn't mean that you have to actually manage or handle the risk. It's really that you check the risk and you advise someone what they do about it. But it was really to help both parties in the conversation feel safe, and then the T is obviously for talk.
I think it was March on stress.
Yes, I was in my head. I'm going stress, and I couldn't remember the first part. Yeah.
That's Neil Greenberg, right?
Yes.
Who works a lot with journalist organisations.
Yeah. Yeah, so he's done a lot of good work in there, and it's him that does the videos in the training as well. And it's a lot of past military people who are involved in delivering the teaching. I don't think the first guy who did mine was, because he was quite laissez-faire and relaxed. I'm not being stereotypical here, but the second guy was, right, it's 9 o'clock, we are starting. We will have a break at 10:30. You will not do anything else during this period of time, and we will stop at 12. and he completely the way it was meant to be. So, and then the other thing we did, which I want to spend a wee bit of time talking about towards the end, is the Space for You individual sessions, because they were one of our later offerings, but for Mary and I, they're probably the most powerful ones.
They're also very difficult as well, because if I found it hard to speak about my trauma because I didn't want anyone to be nice to me.
Yes.
Because I didn't want to break down in tears in front of someone I work with.
Yeah.
It must be very difficult for a male manager who's got a female employee coming in with problems and them having a breakdown, because you're in a very awkward position then as a male manager, especially nowadays, to be able to comfort them or say the right thing. Then you might have to bring someone else in from HR to have these conversations, which might not enable the person with the trauma to open up in the first place.
Yeah, because then they can feel threatened because they hear HR and it's like, no, don't punish me for having emotions. Yeah, absolutely. Well, some of the React mental health training gives you just even lines and ways of interacting with people in order to make that feel safer for you or for others. Yeah, it is. It is. Emotions are a minefield, aren't they? They really are.
Even thinking the States, it was the States
Yes.
who just, it's a macho environment, they don't talk about emotions, but the person who attended one of the webinars coming to us afterwards and said, there's so many people looking in, yeah, I've done X, Y, and Z, and I've checked this and checked that. And by the way, you know, me and the wife aren't getting on, or whatever else was going on for them at home is kind of running away out the door now. I'm thinking, I was like, what do I do with this?
Yeah.
But that allowed him, given the framework, to have a conversation, and it was okay, but without thinking, I have to fix this, I have to sort, I have to make it all better. I just have to be there and listen.
Yeah.
And that was one of the brilliant byproducts of the webinars we delivered to managers, is that some of them picked up on things and went, will you come and talk to our team now? Or will you come, that manager was really keen on the React mental health because of that reason. He wanted a safe way to talk about difficult stuff. And there was a big spread, and that's what we really wanted. We wanted to scale and spread as a result of it. And we thought by giving the information to managers then it would spread out. But we did have a lot of requests then to come to teams in order to give the information. And we were worried whenever we were devising the webinars that a lot of the stuff we were talking about was too basic, like this slide. And Mary and I were even talking the other day, we were like, that's really basic, isn't it? We maybe shouldn't put that in. But we found whenever we were delivering the webinars that people wanted the basic stuff, because often we forget the small stuff and the basic stuff. And we can talk about, you know, people understand to a certain level, you know, trauma and vicarious trauma and all those sort of high-end stuff. But where does it start? It starts with a series of events of feeling unsafe. And whenever we feel unsafe, it's usually an anxious feeling. I felt very anxious when I was driving up the road from Derry and realised that Bruce Springsteen tickets were still in my bedside drawer, and they belonged to me and 3 of my friends. And they aren't the electronic ones. I actually got real proper tickets delivered. And I was like, oh God. I was like, who am I more scared of? Is it Leona and Mary for me being late, or is it my 3 friends who won't have tickets? So I thought I turned. So sorry, you weren't scary in that moment. And then I was, my mind, you talk about being aware of your state, because I was running late then. My mind was sort of in a different place. So I went over to the Mac, which is a theatre just a couple of streets back, and went, I'm here for the Mediastrong conference. And they got blank looks. And I was like, I'll just go in the lift, and in the lift, and there was only 6 floors. And I thought, she definitely said 8. So then I suddenly twigged I'm in the wrong place. So there was this, you know, because of that sort of was psychological anxiety that I felt when I forgot the tickets, and then, oh my goodness, I'm going to be late, and then I could feel it in my body, you know, that sort of the heart drop moment and the stomach drop moment and the fast heart, and still have the dry mouth, but I think that's because I'm talking, and all of those things. And then I just knew that even my brain wasn't firing on all cylinders because it was full of so much other stuff. And we at the webinars made sure we talked about anxiety on a basic level. And I suppose for a lot of us, we do have that image of fight, flight, freeze, or we might have this sort of idea whenever you're anxious, you've got all of these physical features. Now we know the brain and the body are completely connected in every single way. I couldn't be moving my hand like this if I wasn't knowing that when I speak I'm really expressive and I move, and there's information going from my body to my brain to my hands moving, know where it is in space. The brain and the body are completely and inexplicably, as far as I'm concerned, linked in many ways. And we often think about anxiety as looking like that. We can look at someone and go, oh, you're really anxious, aren't you? You know, if you're sitting there and your legs going a mile a minute before you're going in in for an interview or something like that, someone's like, yeah, they're very anxious. But anxiety also can look like this, and these are the ones that might be more recognisable in the workplace. I know that I certainly can relate to a lot of those. Mary, it relates to irritability. She's usually really cross whenever she's anxious.
No, no.
It's just going to work more.
But all of these other things, including like the overindulgence, to try and soothe in an inappropriate way, the avoidance, lack of concentration, and even the dizziness and numbness. So we often get people who present with physical health symptoms, which are as a result of the psychological stress that they might be under. And people can be naturally very, very worried about things like dizziness and numbness. But whenever you look at it, a lot of it can come down to the anxiety, to the stress, to the exposure to different traumas.
I get hot flushes when I'm stressed, like I'm going through the change.
Uh-huh. Right? Do you know what that's like? But yeah, of course, because you've blood rushing to all these places, so that completely makes sense. I love this model by Paul Gilbert. It's a model of compassion, and I love it because it really just highlights where we often are and where we should be. Apparently, I don't like animals. I'm going to put my hands up. I'm not really an animal fan, but apparently cats spend about 90% of their time in soothe behaviours, whereas most humans spend about 5% of their time in their soothing system and soothe behaviours. And what we tend to do is spend a lot of time in the drive system over there, the blue one. And even whenever Hannah, you were speaking earlier, I was thinking a lot about the drive system, and even whenever you're going, yeah, running's really good for me and my mental health, except when I get really competitive and like get into it, and I thought, yeah, that's when she's went from the soothe bit to the drive bit. It's like, I want to do better, go for the better time. So drive usually gets us where we want and is motivation towards resources. But we can spend a lot of time in the threat system, and that hypervigilance and knowing, looking at what's around. And hypervigilance emerges obviously because of the adrenaline, which is keeping your system on edge, which is firing the other things which for fight, flight, etc. And it can be very, very useful, obviously. Whenever I used to be teaching people about this, I say it's really useful, if you see a bear in the woods, which hasn't happened to me in Northern Ireland, but it might have happened to people elsewhere, so that you know either to run away or fight. Obviously, run away is the answer.
Yes, to this guy's point, the point, I don't know,
Yes.
What's your name?
Kevin.
Kevin,
Yeah.
I guess it's probably Kevin's point that he was talking about, like, the lay of the land, when the crowd's going to change, so that's that kind of threat system as well.
Yeah. Oh, absolutely. It was, you're very...
Journalists spend their life on that one.
Yeah.
In a height,
This one?
no,
This one?
they're going into situations knowing they have to control themselves in those situations.
Yeah.
Even though the natural responses in your brain is not firstly to go into the situation,
Yeah.
secondly to get out of them as quickly as you can, but we have to actually go in, maintain our presence in them, and keep ourselves safe.
Yeah. So that's really difficult because everything
we're told, automatically told not to.
Yeah.
Plus, we have to recognise part of it, part of the drive of journalists, they'd say what drives me on, is become adrenaline junkies.
Yes.
Because we're pumping a lot of adrenaline while in those situations. And adrenaline is a very helpful thing.
Yeah.
But when you overdose on it, it's a very unhelpful thing.
Yeah.
Because you start to crave it then.
Yeah.
And you want the next big adventure.
Yeah.
So you start becoming risk averse or risk takers.
Yeah.
Because you need another fix.
Yeah. You almost get addicted to it.
Yes.
It's sort of...
So we actually, what we do is counterintuitive to everything our bodies tell us not to do.
Yeah. So there's two things there. It's about adrenaline and the wear that causes on your body and your mind whenever you're in a constant state. So even though you're saying that you're having to soothe in order to get into the environment.
Well, we have to.
Yeah. But it's like a paradox because you still are, it's the adrenaline that's getting you there. So you're trying to do the two things at once. And how confusing is that for your body? Part of you and your mind is like, this is a really dangerous situation. Be aware, whereas you're saying, I have to maintain this external stance where I can control this. So it's really a massive challenge. And the soothe the suppose that I'm thinking about more is the stuff which helps protect your body, which brings down your heart rate and brings down your breathing rate and brings you back into the moment in a more grounded way. And there's things which are appropriate in terms of soothe and things which aren't. Some of the things which we tend to do in order to soothe ourselves are like the short fixes, like the alcohol or drugs or shopping or different things like that, but they bring short-term gain, and the thing that we need in order to help soothe our system in the long term is more to do with the whole body being soothed and calmed and brought back down. And you mentioned breathing, Hannah, earlier. One of the most effective, or actually I'm going to rephrase that, the most effective intervention that I do with anyone at any stage, children, adults, anyone. Actually, I often do it with children, but I'm actually talking to the parents who are in the room, pretend that that's for the children because the parents hear it, even though they think they don't need to, is about breathing. And it's not about the 4 in, 8 out slow breathing. It's about breathing into your tummy so that your tummy expands and comes out. Because so many people breathe wrongly. I was at a yoga retreat about 8 years ago, I think, and I was with 5 accountants and me. And there was 2 people who could breathe and breathe properly the way that the yoga teacher wanted them, was me and one of the other accountants. The rest were doing what we all tend to do at adults, which is chest breathe, which means you aren't breathing properly. And I saw a child a couple of weeks ago and I was talking about breathing into your breathing exercise. She goes, "No, I'm not doing that." And I was like, but have you tried it? Loads of people have talked to me about breathing. None of it works. I said, "Did anybody talk to you about breathing into your tummy?" She goes, "No, it was all breathe in, hold for 4, exhale for 8. Breathe in, hold for 4, exhale for 8. And she was like doing that, but doing it in her chest, not with her tummy. So whenever you're breathing in, if you want to see how to breathe, watch a baby. Or a dog or a cat or something that hasn't got its... The stress got to it in terms of life. I'm sure there are stressed dogs and cats, but as I say, I'm not an animal lover, so I don't know. But the breathing whenever you use your tummy is just so powerful in terms of helping reduce all of the adrenaline that's in your body, because it's completely counterproductive. You have to breathe deeply in order to get your stomach to go out, and it slows down your heart rate, it slows down your breathing rate, it brings blood to the place it needs to be, and when people do it, they were like, "Oh, that worked." And it actually produces serotonin to help you go to sleep.
Just how many of us are actually trying to do that now?
But
Yeah.
Put the hand on your chest and the hand on your tummy, breathe in, which hands move. Simply say to see
I'm
what
afraid
you're
I'll
doing.
pop one of these shut.
One of the interesting points on breathing is talking about how we inherit our ancestors' nervous systems since the Second World War. Our breathing has been progressively getting faster and faster and faster.
Ah.
So we've actually realised we've been inheriting a kind of dysregulated nervous system from world events.
Yeah.
And that obviously leads to lots of health conditions that we're
Yeah.
not breathing properly. So to retrain our nervous systems
Yeah.
to be pre-1930 to
Yeah.
1920s.
Yeah, it's all about that regulation, isn't it? And just helping ourselves be regulated. And the Manki Satsuma, totally going to steal that. If you see it on Twitter, we'll give you a credence. But it's the spread. If you're in a room of people who are more relaxed, then you tend to feel more relaxed. You're beside someone. If you ever be beside Mary, the hands earlier. If you're beside someone who starts to breathe, more slowly, deeply, using their stomach, and they just put their hand out to you, all of a sudden, you almost like a contagion effect, you'll be better able to do it. I know I've done that sometimes with my youngest son. Sometimes if he's upset, and if I'm lying in bed beside him, and I just start doing the breathing, and then he starts doing the breathing. You haven't said anything, but they're modelling. You're modelling for them, and I suppose that's what we want the managers who we were working with as well to do, is start modelling things as well, and making it okay to talk about some of the things that we felt were important. I popped this one in yesterday just because it looked at some of the reactions that there can be to threat. External reactions, internal reactions, and some of us don't recognise the internal reactions. We're more, react more externally. Some of us just turn it all inside, and it's like, oh my goodness, I'm so bad at this. This is terrible. Or else they isolate themselves because if it's a flight response, because they don't want to be around people, or they kind of over-identify. And the antidote to all of that is self-compassion, and it's really, really hard to do. People are really bad at being compassionate to themselves. People are really bad in Northern Ireland even at speaking positively about themselves, because we've sort of been brought up to be negative. My mother would say to me, "I know you, I know where you're from, don't you be getting too big for your boots." And when I used to send people to camps in America, good camps, Camp Counsellors USA it was, for summer experiences, the young people in Northern Ireland rating themselves, now this was 30 years ago, or 25 years ago, but the young people in Northern Ireland rating themselves would give themselves 7 out of 10 if they were grade 8 in piano. And I'd be like, it's more like a 10. And they're like, oh, I couldn't put a 10 down. And I'd be like, well, the people in Dublin who have grades 5 in piano are putting a 10 down. And they're like, are they? Okay. And then I say the camp director won't hire you to teach piano unless you put a 10. But so people are very bad at being good about themselves. They're very bad about being compassionate towards themselves. We did a project in the trust as well last year, which fed into some of our work, which was looking at self-compassion. 28 days we asked people to rate themselves on a self-compassion scale and to rate their compassion for others. The change was phenomenal in their perceptions, because they were actually paying attention on a daily basis to how much compassion they had for themselves. Their scores on the psychometrics went really, really high, but more importantly, it changed their practice. Doctors and nurses were saying, I took a break because I realised I needed one, and I was going to be doing more harm by keeping going on, but I needed to look after myself first. Doctors, and one of the doctors' quotes said, I went into that patient, and though I realised that I needed to be more compassionate to them, because instead of just going in and breaking the news and moving on because I'm under pressure, I took the time to do my job properly, and I sat with them for 20 minutes. That patient was discharged the next day. She'd been hanging around for about 4 or 5 days saying, I can't go home, I can't go home, I can't go home. But when someone took the time with her, she was able to go. So it not only helped the patient emotionally, it helped the doctor emotionally, and saved the health service money.
Is that not a conflict society related? Because we always know somebody who's much worse off.
Mm-hmm.
So we all assess ourselves as bloody lucky.
Mm-hmm.
We just escaped with broken arm or whatever.
Yes.
Someone else lost 2 legs.
Yeah.
We do that in
It always
conversation as
people
well.
are
It's
worse
like,
off.
I can trump your story, you think that's bad.
Yeah.
we have that as well.
Remember my mother was born in the 20s when she had cancer, and she was on one of those morphine things where you get the self-injector. She wouldn't use it. She was, there's always someone worse off than me, they can use it. It was like,
Goodness.
That was that generation. It was like mustn't grumble, we just get on
Yeah.
with it.
You get that in journalism a lot.
Yeah.
So like people, with the vicarious trauma versus the I'm in situ in Ukraine reporting,
Mhm.
like, and it invalidates your experiences if you feel like
That's going back to what we were talking about earlier. The adrenaline buzz. Oh, I've been in a better war zone than you were in.
Yeah.
Mm-hmm.
And it perpetuates.
Yeah. And yeah, we do have the impact of intergenerational trauma here as well. Definitely. So with our regulation, we need to do a lot more of that. I love this as well, and this is one of the things we would have used in the webinar too, just about the importance, again, the brain-body links. And we use this for managers because often they will be trying to tell someone something or reason without understanding that people aren't going to get it unless they're feeling regulated. So it goes back to what we're talking about regulation and about regulating first. So even though it's a graphic about a child and a parent, it's completely irrelevant for anyone who's having conversations or where there's any level of dysregulation. So sometimes it's about regulating ourselves and sometimes it's about regulating others, and it's just really about any ways of increasing awareness about the importance to regulate stress in order to be an antidote to the stress and the trauma and to promote better outcomes in terms of mental health. We'll come back to the baby mobile again. So it seems like a strange thing to put up sometimes, especially in the middle of a webinar for managers, but it's really to highlight that the baby mobile works best whenever everything is at the same tension, whenever the strings are all the same length, whenever everything's working well together. It doesn't work if one part of the system, one part of the string is broken. So it's really highlighting that all the systems need to work together, our own internal systems as well as the systems that are around us. And often we find that one thing works well in one area but not another. So our aim is always to try to get the systems in balance, to get the baby mobile working and moving together. And I actually got that idea from a podcast that I was listening to one day. It was one of those interviews with somebody quite famous, but I was going, I love that analogy. I love the idea that just we have to keep all of the parts of the system working together, and it's a real visual one, the baby mobile working together. We talked in the slide about the culture earlier on and about having to get the vision and get the change, we talked about getting buy-in, small seeds of change. This is a graphical representation of the psychological support that was offered across time. And we did this work for over 2 years, so this is part of that. But you can see that from when we started to when to 3 months before we finished, you can see the take-up had completely increased. It started low, started slow, and then it went really quite high in terms of what people were looking for. And a lot of that was down to that spread, about the spread of information in terms of what people found to be useful. And it was one person saying to another, this is maybe it might be the Space View session. We talked to Mary, we found it really useful. It might have been they had a webinar and they went, you should get them to do a webinar for you, or else get them to do a team session. But it took time and it took a while for the culture to change, and it then accumulated over time. And the other thing, I just got distracted there because I was thinking the other thing I wanted to say was at the start, in the most acute phase, there was a relatively low take-up. Some of it was because people didn't understand what was being offered. Some of it was because people were going, my mental health's fine, I don't need that. Or there's people that are worse off, we don't need to go along because someone else. And we did hear that a lot. We thought someone else would need this space. But what we do know from the research is that even knowing that there's an offering can be enough for people. You don't necessarily have to have it used. So some people are going, you see, that's not worth anything, nobody's using it. But the research would tell us the fact that people knew it was there was often enough of a reassurance that they were being taken care of. Yeah, exactly, a safety net. The Space for You sessions that Mary and I offered were 1 hour sessions which had no agenda, which were offered to people through the hospital media. They were advertised through email. They were advertised in the webinars we did. I think there's handouts, posters as well, just about them, and just invited people to contact us if they wanted to use a 1 hour session. And we weren't sure how they would go, and we didn't want to have an agenda because it wasn't going to be a therapy session. It was just going to be a space which was available for people to use in a way that they wanted. And as you can see from some of the ratings there, 100% of people indicated that they had a positive experience, more than 90 that they would recommend the service to other, and more than 80 that they would use it again if they needed to. More than 90% said that the spaces helped them to remain in or return to work, and 100% said they found the service helpful. And there's some of the quotes on the other side about it. And we had people saying things like that, as we said earlier, we didn't think that anyone, we didn't know what this was going to be about, or I didn't know what I was going to say, or I thought someone else might have needed this space, so I've put off coming, but I'm so glad I did. Or Mary and I were thinking, what are people going to talk about? Are we going to use the session? It's meant to be 40 minutes, but we both tended to nearly use the full hour. People came in. They went, I don't know what I'm going to say 1 minute. The next minute, the hour is gone. And they're like, whew. And we've hardly spoken because they've really needed the space. They've needed the opportunity to tell their story and to be heard in a non-judgmental type of way, or to process things. And often we're told, I've never said that before. I've never told anybody that. Or I didn't think it would be okay to verbalise that. And some of it was basic, really basic, simple stuff, and some of it was more complex. But and it started with the COVID stuff. But by the end of the 2 years, we were hearing all sorts of different things. It wasn't just about the COVID. It was often the start of a process. COVID was that, the capacity cup was that final layer, but there was lots of other stuff underneath. And several people have mentioned tea. I think everyone's thinking, where's the lunch now? Everyone mentioned tea. And I love this because it really highlighted what we found in the Space for You sessions, that the importance of sharing it and the importance of sharing information. Even if you think it's not going to be helpful, you often find that it can be. So
the tea and talk as well, from the team sessions, a lot of teams
Yes.
then went off. It's like everybody, Friday morning, 10 o'clock with your tea, everybody's online because they're all working from home, just so that they were connected. And that importance of connecting, even if you're not all in the same room at the same time. And that was just tea and talk. Really simple things, but people weren't doing it. Yeah.
It's amazing that you had mentioned stories as well, Hannah, but it's something in all of my clinical work and the research that I do as well, and the work with Mary, it's always the stories that are most important. I mean, you tell stories, that's your job, but it's the stories that are so important for the people. We've done some gorgeous research where people have been able to tell their stories, and the themes that come out are huge. We're doing a piece of research at the minute with children of parents of children who were born with congenital heart disease over 20 years ago. We enabled parents to tell their story in the intervention group, not in the control group. We've been following up the parents now, 20 years later. The difference in the traumatic memories of one group versus the other, and the visceral memories, are huge. And there's lots of different aspects of the intervention, but a key part was that narrative bit, enabling them to tell their story at their time. So in telling the story, it was processed better. So where do we go next? What can we do? We, as Leona mentioned, Mary and I and Catherine Murnan, who's in the room as well, are working together in order to try to devise a pilot programme to take things forward. Catherine does work in something called the Wellbeing Pathway, and you can speak to her if you would like to. These are her details. She's third row back, black top, short hair. And I've known Catherine for a lifetime. You know, a lot of this is about connections. I worked with Catherine whenever she was the chief executive of the Children's Brain Injury Trust. Is that right? Yeah. She's had several iterations since, and now she does this work. And what we talked about a suite of options that we needed within the trust, and we recognised in developing the pilot programme, we need a suite of options. So it needs to be something that's, you know, that directly about the mental health, mentions the mental health, but there's also something, because people, and I get what you're saying, Hannah, you know, just call it mental health, but for some people they just can't yet. They need to start with the wellbeing and then move into the other stuff as well. I have the same difficulty because I work a lot in infant mental health, and people don't like me talking about infant mental health, and I'm like, why not? You want them to be well, don't you? But the programme that we're pulling together has many different elements, including Catherine's work and some of the work that Mary and I have done, and the work that Leona's doing. And we're trying to pull that together to something that meets the needs of the people who would use it. And we can't do that completely on our own, because we need to make sure that it's informed by the people who would use the service. So that's why Leona will be contacting you probably to ask you for your thoughts and any directions that you think that you would like the programme to take. If there's anything from today in terms of Mary and I's talk, or the things that Hannah's talked about as well, that you think, yeah, absolutely, that sounds right. That's where we need to go. But we're really keen on a co-production approach to that. So we'll be asking for more information about that. We just want to make sure we get it right, and that it's partly informed by the co-production. But what we do know is the importance of looking after staff and promoting good mental health. And we know about the importance of strengthening self-care, compassion, psychological safety. And we know that when we do all that it can be an antidote to trauma, that there's no script that says it has to be a negative outcome or a bad outcome. Poor mental health can turn into good mental health with the right things put in place. And there is a chance for there never to be the poor mental health if we get things right from the start. Thank you.